There is a common theme in your stories, and that is you get started and you're either worried or you become quickly bored with what you're doing and you're looking for the next thing. I mean, I don't know if you picked that up when you were just telling me the story, but certainly we talked about this with coronary angioplasty. Can you kind of get a little bit more into details how you hopped from one to another and ultimately how this got you into where you are now?
It may be my obsessive compulsive problem or my ADD, right? But the fact of the matter is, I really love new things, as do you, and which is the thing that got us together in 2000. And so when there was something new on the horizon that nobody was willing to be full-time about or three-quarters time about, that was something that I thought was fun. Maybe I should do that. And multiple times during my career, that's what's happened. It happened with the mitral valve, when we did the mitral balloon valvuloplasty, opening it with a balloon without having to operate on these people, and it worked beautifully. And then when I got tired of that, I do remember saying to one of my partners at the time in 1990, we're done with mitral stenosis. We've taken care of all the people in the United States, essentially, that have this problem. It's time to move on to something else. And that's when we got into the aortic valve. And that's where I started thinking about how to build a valve and how to make a valve. And then when I met you in 2000, things were just heating up in the aortic valve era. As you remember, we worked out a plan where you could take a year off after your interventional fellowship to go to France. So that was the beginning of the era of the aortic valve, and that's sort of when I met you for the first time.
So it was my first rotation
As a
down
fellow.
at the public hospital at Grady, and I think I was your first fellow, clinical fellow. You had come from Portland, and you had been recruited to take over a lot of the clinical research that was going on in cardiology, or at least help in that aspect with clinical trials at Emory. And we overlapped at Grady.
That's correct. My first rotation as a clinical teacher at Emory
Yeah.
was at Grady in the cardiology section, and you were the fellow.
I was the fellow, and I think what you liked was that we could expedite the rounds and
Exactly.
be able to see patients very quickly and efficiently together. Certainly not overlooking any details, but we'd get down to the point pretty quick, and I think you and I, we kind of bonded over that aspect.
I think that's correct. And in fact, I think we had a lot of fun because we could do things, one, efficiently, end up doing them rather well, at least we thought so.
Yeah.
I hope that's true.
Yeah.
And it worked out that we really developed a bond during that 1 month. And at the end of that, we sort of decided, I think, between the two of us, that maybe we could continue to work together as this structural heart business began to develop within the Emory system.
Yeah. I think and I've probably told you this, that you favor one of my uncles, the one that drove the bus. Do you remember this?
Yes, I do remember that. You should tell that story.
He was a wonderful fiddle player, and you had the same hands and the same coloring and so forth, and looked just like him. So in many ways, there were a lot of connections that were occurring, but ultimately, what really struck me is that you took an interest in me, which was something that I had not realized until later, but you had taken an interest, I think, in a lot of fellows and the development of their fellows. You were mentoring in something that we hadn't seen in a long time, and I don't know if it was because it was stage of your career, because you were moving to a new place. Maybe you can tell us why that was.
It's really very simple. I started at the MGH in Boston, and my role was to teach fellows how to do heart catheterizations when that was all we could do. We didn't do anything except diagnostic things. And then as that developed into more interventional things, I continued to spend most of my time teaching in the cath lab how to do certain procedures and how to think about certain kinds of heart diseases. And then when Went to Portland, the same thing happened. I had a fellow there who was at my side all the time, and I spent 10 years teaching there too. So I came to Emory essentially as a clinical teacher more than anything else, but with a strong interest in developing this structural heart program, which is why I was recruited. So the teaching part was easy. Why I enjoyed teaching you was, number one, you were a reasonable student and very receptive, but you also, I recognized very early on, had really good hands. And one of the things about watching people do certain specific techniques in cardiology is, if you have seen a lot of that, it doesn't take very long to recognize people who can do it well versus who can do it not so well. And at that point, it's important to tell people, maybe you shouldn't be doing this, or, I think that I really enjoy working with you, and maybe we could develop your skills a little bit more and ultimately work together in some way to make this a more profound combination. And that's essentially what happened to the two of us.